Top Med Talk.
Hello and welcome. It's Top Med Talk here at EBPOM London 2023. I'm Desiree, Chappell, your host. I'm joined by my co-host, Monty Mythen. Hello, Monty.
Desiree, great to be here, back in my hometown.
It is your hometown. This is your meeting, man. This is it.
Yeah, we've been at it for a while now, a few decades, started in the last century.
Yeah.
The early movers in the sort of the latest version of the perioperative medicine movement.
Yeah.
And here we still are.
Yeah. So this meeting this year, Monty, traditional EBPOM, but
it's the World Congress of
Yes.
Prehabilitation. So we were lucky enough to co-host that meeting a number of years ago at the British Museum. And it was a very, very successful meeting, our biggest ever.
Mhm.
And there was discussions at the time that the word of the year would be prehabilitation.
That's right. We did
But
say
it
that.
turned out to be COVID.
That is so true.
Or whatever it was, lateral flow test or something.
Yeah.
I can't remember. But,
I think it turned into
yeah,
COVID.
we can laugh about it now. But
Yeah.
so here we are revisiting it, and a great turnout of people who are still very excited about the opportunity to give our patients a better chance of success in major surgery by doing predominantly very simple interventions,
Mhm.
activity, nutrition, tidying up all your comorbidities, giving yourself a little bit of time before elective surgery to give yourself the best possible chance of success.
Yeah, I think it's great because I think everyone is kind of bringing it back to there's all these very complex things that we can do. But let's see what's practical and what we can actually implement at our shop and make a difference.
Yeah, simple, as you say, very simple things like giving yourself a walking regimen, a timed number of steps, of dietary modifications. There are some fancier nutritional supplements you can take, but even if you can't do that, a plant-based diet and eating sensibly and cutting back on the meat, there's all reasons why that will make things probably a bit better.
Yeah, absolutely. And then day 3 of EBPOM, big deal.
So day 3 is back to traditional EBPOM.
Yeah.
We start the day with the results of Optimize 2. So
Drum roll, please.
We recorded Rupert Pearce recently.
We did.
In Glasgow at the European Society, where it's a great piece where he goes into detail about Pearce's folly, as he calls it.
He did call it Pearce's folly.
The journey that's been most of his adult doctor life, exploring whether improving oxygen delivery and perfusion around the time of major surgery makes a difference to outcome. And 5 years in the performing, maybe up to 10 years in the making, and the result will be announced on Thursday morning. Over 2,500 patients. Now, for those of you who are very interested, you can listen in and you'll get the results. It's really, really important, I think, that you take the time to listen to Rupert's explanation of the study design and the question that was asked.
Yep.
Because it's a slightly unusual question.
It's very specific.
It's very specific. So go and have a look at that, because it's that's the challenge of doing RCTs. Yeah. It will answer one question. Yeah. You may not be interested in the question.
The question definitely has manifested and evolved, I guess is the word I'm looking for. So, but that's what it was 5 years ago, and that's what we're going with. And I think it's going to be great if this definitely will be going out after the fact, I think. So all of this information can be found on Top Med Talk.
There's one other bit, which is the fact that we're also having the results of the POCI, the Perioperative Quality Initiative update meeting.
Yes.
Which is over the years now. POCI's on its 11th, 12th, 13th.
11th. Well,
this is the 11th. Yeah. They've got planned the 12th and the 13th. They've just done the 10th. And this one is a first refresh to revisit 3 components of perioperative care. And that is the choice of intravenous fluid. Once you get into the surgery itself, it'll come down to colloid, crystalloid, lactated venous saline. God, you think we'd have sorted that one out?
You would have thought.
Blood pressure threshold, target thresholds is 65 millimeters of mercury, the magic number, or should it be customized? And so-called goal-directed therapy, which is going to be in the context of the Optimized 2.
It's tough to do this one, Monty. I'm sitting on that one, and we don't know the results.
Yeah, but there's goal-directed therapy, and there's the question that Optimize 2 asked. And Optimize 2 asked a question about one component and one way of doing so-called goal-directed therapy. So I'm looking forward to it.
I am too. It's going to be great.
I have not been in the room, so I'm very excited.
You have not been in the room.
I'm like a kid before Christmas. Look at all those presents I get in one morning.
That is, one day. Well, if you missed any of this or you didn't see it live, all of it is recorded and out on Top Med Talk. So be sure to look at that. Well, Monty, one of the things that we talk a lot about, and we had a great discussion at ESA around the time of ESA, was about enhanced recovery.
Yes.
And, we've had multiple discussions about how we measure enhanced recovery and the success of those. And one of those ways is not actually looking at all the specifics of, each component of enhanced recovery. It's kind of looking post-operatively to see how the patient actually did.
Well, apologies to retell the story. When I was lucky enough to be involved in our first attempt in the United Kingdom to have the widespread adoption of enhanced recovery, which is about 2008 to 2012, kind of standing back and look at the available literature, how do you judge if people are really doing enhanced recovery?
Yeah.
And to cut a long story short, if people are sitting out of bed having breakfast the following day, they're probably on an enhanced recovery program.
Yeah.
And out of that came the idea of drinking, eating, moving, and then the sort of acronym DREAM, which I think is stuck.
Yeah.
It's not, we didn't come up with it. There's prior art in that space that leads you to that point. But the concept of saying, how do you quickly determine if enhanced recovery is happening effectively? We'll go around and just determine what your dream rates are.
Yeah.
And if they're very, very high, 80, 90%, then you probably are going to find your results are good and you don't need to look upstream. If they're not very good, you'll probably find that there are things you can do that will improve outcome.
Yeah.
But now when we introduce our guests, we're going to expand all of that in the years that have followed to really do something meaningful about that.
We are. And I think we've started this conversation, I think several years ago at Prato, but here joining us today is a guest that a top med talk fan fave, Ramani Moonesinghe, to talk more about the dream and all the work that you've done in this space. Ramani, thank you so much.
Thanks, Desiree. Great to be here and lovely to see you and Monty in London.
Absolutely. I know. It's great. I feel like every time we see each other, it's actually not in London and it's all over the map, but that's all good.
Oh, and not through a screen, which is
I know. I know. That's great. Well, Ramani,
I thought you don't mean a confessional or a prison scene. You mean on Teams or?
Yeah. I kind of mean that. Yeah.
Because I've suddenly had an image of orange jumpsuits.
You and orange, Monty.
Fast forward.
That's right. Ramani, we've had numerous conversations about all different types of things because you have done so much work here in the NHS and here in the UK when it comes to perioperative medicine. And so it's almost like I don't know exactly where to start, but let's start with just introducing yourself. Tell us a little bit about the evolution of your practice and where you are now. And just give a little context for some of our listeners that may not have heard previous conversations.
Brilliant. Thanks, Desiree. So I am an anaesthetist and intensive care doctor by background. I am one of Monty's children from an academic perspective.
Not so long ago, right?
No. One of his adult children, having undertaken some research in Monty's department for the first time, actually towards the end of my training, about 15 years ago, under Mike Grocot's supervision. And I now have a few different roles. So I still practice clinically, although quite a limited practice focused on preoperative assessment. I do some research. So I'm a professor at UCL, and I am the National Clinical Director for Perioperative and Critical Care for NHS England, which is our overarching organisation that drives the NHS in the UK, in England itself. And my research includes the Perioperative Quality Improvement Programme, which is a multi-centre cohort study, which aims to try and improve our understanding of the epidemiology of perioperative outcome, and also to drive improvement through measurement and feedback to clinicians.
A little bit more context, Ramani.
Yeah.
I mean, many people around the world have heard of our National Health Service, but it provides the vast majority of healthcare in the country.
Absolutely, yeah. I mean, I don't know the exact numbers, the divide between private and public, but it's vastly weighted towards public sector NHS treatment. We all pay for it through our taxes. We are able to access both elective and emergency care through that route. So, yeah, I mean, everybody uses the NHS.
And we do, as many countries do have, but not all countries do have. I think USA is an exception. We do have a unique patient identifier that follows us around.
Yes.
So we can link our NHS number, our hospital number, and our so-called national insurance number, our sort of tax codes. We're allowed to link them all together to try and understand what's happening.
Yeah, I mean, there are many advantages of our national system. So one of them is exactly what you've just said, Monty, where we have a unique identifier, which means that from a research perspective, we can look at patient data, even if they access different hospitals and so on, we can look at the patient linked by that unique identifier across healthcare providers from a research perspective. From a research perspective, again, one of the things that is amazing is our National Institute for Health Research, which links every healthcare provider in England. And what that enables us to do is to galvanize the troops very quickly sometimes and very effectively most times, deliver really comprehensive generalizable research. And the whole world knows the achievements of the recovery trial in COVID, which was a great example of how the system in England, in the NHS, supports rapid, high-quality research that, in the case of recovery, sort of led us out at that before vaccines, led us out of the pandemic.
Yeah. And so tell us a little bit more, going back to PQIP. Let's dive into that just a little bit more, because I think that you guys have looked at some of the big questions that we have around enhanced recovery and success of patient care and perioperative care. So PQIP, tell us a little bit more about how that works, how you gather the information. I would imagine, because of these patient identifiers, it's a lot easier to do. And
well, sort of. I mean, in some respects, it's quite a traditional research study in that hospitals sign up to take part in it.
Okay.
We've got local researchers that then recruit patients into the study. Patients consent to participate. And the thing that's pretty cool about PQIP is the comprehensiveness of the data set, because we collect both objective data, the patient's health risk factors, and also their objective outcome data, like their complications and so on. But we also collect subjective data, so patient-reported data. So both patient-reported data in terms of health-related quality of life, but also other things like their smoking and alcohol habits and their exercise capacity and those sorts of things. And we collect longer-term outcomes than we normally record in clinical studies. So, we are very fond, because it's easy, of measuring things like inpatient or 30-day mortality. We measure that. But more importantly, perhaps, we measure complications inside the hospital, and we measure health-related quality of life at 6 and 12 months after surgery, including disability, using validated metrics. We're 45,000 patients into a 70,000 patient study.
Wow.
And we analyze the data as we go along within the capacity of the team. So I think we're going to come on to talk about one of our first research papers, which focused on the dreaming question.
Yeah.
We've got such a wealth of data. We're a bit like, children in the playground. We don't know which
overwhelmed with choices.
So it's a great opportunity. And through the system that Monty mentioned earlier, through the sort of national identifiers, what we can also do is link to government administrative databases that tell us things like hospital readmissions, days spent in hospital, and ultimately also death and date of death, and so timing after surgery that death may occur. So we can collect that data automatically and analyze it, and that's hugely powerful as well.
Yeah, absolutely.
So to remind ourselves, when I told the story about where the national team back in 2010, for example, ended up with the idea that achieving dreaming, in other words, patients sitting out of bed, having breakfast, having been for a walk, was associated with a good outcome. That was high-level anecdote. It had no evidence behind it. It was supported by one small previous study. It was in Henrik Kellett's original recommendations, and it looked to us as though it represented good. But I think you all followed up to demonstrate the fact that that may or may not be true, in which you explored it properly.
Yeah, absolutely. So when we designed the data set for PQIP, one of the things that we were really keen to include was the dream, was understanding the compliance of individual patients against the target of drinking, eating, and mobilizing within 24 hours. And Monty, you'll remember this because I came to you for advice about actually, it's kind of easy to say it, drinking, eating, and mobilizing, but actually, what does it mean? Drinking how much, eating what, and mobilizing in what way? And so we refined the definitions so that everyone was measuring the same thing. And that's really critically important. So it's drinking free fluids. It's eating.
There's no volume target.
No, I was just going to say volume target. Okay.
No, there's no volume target. And we measure whether the drip comes down separately, but I'll come to that in a second.
And is this patient reported, I'm drinking this much fluid? This is a nurse saying.
This is a nurse saying they're drinking free fluids, or a health professional saying they're drinking free fluids. Eating at least a soft diet. And
within 24 hours.
And mobilizing with a maximum support, assuming normal mobility preoperatively, mobilizing with a maximum support of one person out of bed and into a chair within 24 hours. So the mobility one is you could argue it's quite limited.
Yeah. But it's not like walking down the hall.
Right.
Which that's a lot of people when you think of mobilize that they're doing laps.
Absolutely.
It's not necessarily.
Yeah, no, it's not. So those were the definitions, and we were they're quite tight definitions, which is reassuring because it means everyone's measuring the same thing. And we separately measure whether or not the drip comes down within the 24-hour period as well.
So for people who are skeptical about this, to put it very, very simply, you do a ward round, and we would expect now in the part of the NHS that we worked in, that a post-surgical patient would be sitting out of bed, having had breakfast, and the drink has got stuff missing from the cup, and the food is at least partially eaten.
Yeah.
And they're not nauseated. They're not holding up.
They're not throwing up.
They're not throwing up. They're saying, yes, I've had some breakfast. I'm not that hungry yet. And they have been out of bed. It does come down to being that simple, or that has to be consistent.
Yeah, absolutely. That's exactly it. And I will share, not to overshare, but I had surgery about 6 months ago, and I felt it in action, and those were the targets that I was set. So it was pretty cool, actually, knowing what it was like to actually, I'd had a spinal anaesthetic and a general anaesthetic for benign surgery, but, it was really cool to actually
live the dream.
What it was like. Exactly. It was great.
Living the dream.
And I dreamed within 8 hours, I'll have you know.
Good for you. That's awesome. Well, so one of the questions that I have, Ramani, is that the pushback that we get a lot, that I get as a quality person and talking to the teams about like measuring what we're doing, is that it's really almost impossible to get all of this information all the time on all of our patients. So, is this something that you guys continually collect on patients every single day, or is this like a snap audit, or how does this work?
Okay, so in PQIP, there's a sample of patients that are recruited from each hospital that we collect the data on. But what's fantastic is since we published our first paper, which validated the concept, essentially found that dreaming within 24 hours was associated with a reduced length of stay and a reduced complication rate in inpatients, the NHS has adopted dreaming as what we call a sequin, which is sequin stands for something not very interesting, but essentially it's a sort of financial incentive. So basically, if you achieve over a threshold target, then your hospital gets a little bit of additional cash, put very simply. And in the first year of the sequin, we looked at a relatively conservative list of procedures, big resections essentially, and joint replacements. And in the second year of the sequin, we've gone for a much broader range of procedures and a higher threshold to get the dosh. And the reason that we were able to do that is there was really good uptake of the sequin in the first year, so we've pushed a bit harder. And what's really fantastic is that what it means now is that it's more of an opt-out than an opt-in kind of thing. It basically, pretty much all surgery is included within the dreaming concept, apart from a few exceptions for specific reasons, like, some complex spinal procedures won't be able to mobilize, some head and neck procedures won't be able to eat. But what we're also encouraging is compliance with the individual bits of dreaming, even if you don't do the whole bundle, because our research found that there was incremental benefit associated with doing the individual bits as well.
If you take us back to the published, let's call it the observational study.
Sure.
As I recall, I should be able to recall it because I'm lucky enough to be a co-author on it. Memory is what memory is. Tens of thousands of patients?
Yeah, so 22,000 patients in total.
And you then divide it in so-called quartiles, so the best 25% as judged by a high level of dreaming compared to the lowest 25%. What was the difference?
Yeah, so it was quintiles, and the best performing hospitals according to their compliance with dreaming in a subgroup of patients having a very homogenous set of colorectal procedures. So 7,500 patients, 111 hospitals, and the best performing hospitals had a 2-day median length of stay shorter than the lowest performing hospitals. So the top was wrong with this. So the top 20%, how
triple dream metric?
Between 83 and 100%.
Well, so some places had everybody dreaming.
Yeah.
And their outcomes, by whichever way you looked at it, were much better than the other end of the spectrum.
They were.
And how? Because we thought we'd sort of done total enhanced recovery, which we kind of knew we hadn't got full coverage. How off the mark were the lowest 20%?
Down to 0.
Okay, 0 to...
I think it was 20%. Sort of.
Oh, just 20%.
Yeah.
And a bunch in the middle are hovering around the 50%-ish mark.
Yeah.
Which means
actually 0 to 33%, the bottom quintile.
So that's all published in the British Journal of Anaesthesia.
It is.
And other sublayers associated with that, subgroups and things that might make a difference. And blah, blah,
right.
Blah.
But the middle part's interesting to me because, a lot of people say, well, we're doing this, but they're only really achieving about a 60% rate, but they're really not doing much of anything. And so they're not really seeing the benefit.
Yeah, that's true. And I think, so always the opportunity for improvement is greatest in the worst performers. Yeah. The places that start at the bottom of the pile. And the hardest bit is moving that middle section. Yeah. Because they kind of, one of the things that we found was that when you did some of the fancy stats, that interpreting it made you realize that there is something culturally different in that. And I know it sounds odd that you can use statistics to interpret culture, but
I think so.
It pointed towards cultural differences between institutions, both in terms of the proportion of patients who dreamed and also some of the fancier statistics that recognized that it wasn't all about the stuff that we were measuring. It was also about some of the stuff that we weren't measuring. We know that there are some things that predispose patients to dream or not. So there are some fixed factors that you might argue can't be impacted on. So, for example, increasing age, but actually there are quite elderly people who do dream within 24 hours. So it's not a de facto that if you're older, you won't dream. ASA grade, so higher ASA grades, less dreaming. But I would argue that even with ASA grade, there's the potential to impact on ASA grade with pre-optimization, prehabilitation, and so on. Preoperative anemia was a predictor of not dreaming within 24 hours. That's definitely modified.
Oh, that's really interesting.
Right. For all of us that are working in the inpatient setting, I think the really important key things were severe postoperative pain in the recovery ward predicted not dreaming. And that kind of makes sense. And the other thing was an epidural. And I don't think it's the fault of the poor epidural. I think it's more the...
Good or bad?
As in having an epidural predicted not dreaming.
Okay.
My interpretation of that is don't throw the epidural out with the bathwater. This is likely to be patients tethered to beds as a result of having an epidural in, inadequate epidural analgesia, which, we all have looked after those patients, and that's a catastrophe, where the epidural fails or is suboptimal. So, and not having the sort of mobile epidural kind of philosophy.
Guidelines that say if you have an epidural, you can't get out of bed?
Potentially, yeah, absolutely.
Yeah,
so
those.
These are the sorts of things, but then on the other hand, we've also, through qualitative research that we've done on the side, found the things that culturally make a massive difference. And it's simple stuff. So it's things like, for a start, your hospital protocols and policies default to dreaming. And so it's the opt-out thing, rather than having to write it on every anesthetic chart or every operative note that the patient can dream.
So that's like an order set, right? Because let's talk about EMRs.
Yeah.
All you would put in there is that the expectation, not all, but the expectation that they have orders to walk. They have orders to advance the diet. Yeah, exactly. So you follow the protocol unless somebody said otherwise.
So in our surgical intensive care unit, one of our satellite hospitals at UCH, everyone was expected to be in the intensive care unit, was expected to be sitting out of bed after major surgery, unless there was a specific instruction not to do that.
Yeah.
Fair? So everyone's on, everyone gets out of bed, everyone has breakfast, unless there's a reason not to.
Yeah. Ramani, I know you've been so generous with your time. A couple more things. One is, how does this affect patients? Patient safety, patient outcomes. What does this mean for patients?
Okay, so patients, we've done quite a lot of work engaging patients with this concept, and they're really keen, and they want to embrace it. And I think another thing that we found through our qualitative research is that using the patient as the advocate for dreaming is really important. So
I should be out of bed right now.
Right. Treat it as if you're in a hotel. Yeah. This one thing, treat it, the expectation is that I should have a drink, I should have some breakfast or some dinner, blah. And if the patient knows what's expected of them and we empower them to ask why not, then we kind of make all of our lives easier, actually. Even the hardworking nurses on the wards who are having to make all of this happen, it should make their lives easier if the patients engage with it.
Yeah.
So preparing patients, there's a role for surgery schools in this. There's a role for the preoperative assessment clinic in this. This is the expectation, and, part of your role as a patient in your own care is to help us deliver this.
Yeah, absolutely. So there's a new PQIP report that's coming out. Tell us a little bit more about that.
Yeah, so that's going to come out on the 11th of July. So we analyze around 45,000 patients, about 12,000 new patients in this cohort since the last report. We see incremental improvements in some things, like dreaming, for example, but some things remain stuck. And this is, really, for me as a clinician, conceptually hard to understand. So this is not critical of anyone because everybody's working as hard as they can in a really difficult environment, made more difficult since the pandemic. But there is some simple stuff that we're not doing reliably. So measuring HbA1c, just measuring it, let alone acting on it, measuring HbA1c in patients coming from major surgery, it's not happening 100%. It kind of hovers around 80%. Correcting severe anemia before surgery, not even having a hemoglobin over a threshold, but recognizing that the patient's anemic and then putting them on investigating it and treating them, not uniformly happening. Dreaming, not uniformly happening. And individualized risk assessment, which is a big area of interest of mine. Personally, even a qualitative individualized assessment, like you are higher or lower risk than the average patient having this procedure, even that kind of assessment isn't happening uniformly. So we kind of provide an individualized risk assessment on about 70% of our patients. And these are patients having big operations. These are not people coming for
hernia or
little tiny things. Yeah, exactly.
So the stimulus for the UK National Enhanced Recovery Partnership Programme was the fact that following the global financial crisis, 2007, 2008, we were broke. We now appear to be broker. If such a thing exists. Is that being taken as a stimulus to revisit these things? Because all the information, all the opportunities are in everyone's filing cabinet, on everyone's notice board. What's the disconnect between the talking and the walking?
Okay, so I think now, in the same way that the pandemic saw huge innovation come out of adversity, we now have a sort of long tail of innovation coming out of continued adversity as a result of predominantly the elective backlog in the UK National Health Service, which I know is affecting health systems worldwide. We've seized the opportunity, those of us that are interested in perioperative medicine, to make the case for the fact that perioperative medicine can be part of the answer to solving that problem. Because if we reduce length of stay, if we prepare patients for surgery better, if we do all the things that we know are the right things to do, then we can reduce cancellations at the last moment, which improves the efficiency of the service, it improves the throughput of patients, and so on. So we've got a national program for perioperative care, which we've never had before. There have been single important programs like the Enhanced Recovery Program that you led, but an entire program for perioperative care has never happened before. And that's because everybody now is behind the concept and they understand that this has something to offer, not just in terms of short-term surgical outcomes, but really importantly, the longer-term population health challenges that we have, the prevention agenda, reducing smoking and excess alcohol and obesity, all that stuff that this prehab conference that we're at is promoting. That opportunity is being seized now in the sort of national policy sphere. And it's one of the good things that has come out of the adversity of the pandemic.
Yeah, that's fantastic. Ramani, wrapping up, anything else that's going on that you wanted to give a shout out to or?
No, only to thank the team who support the PQIP project particularly, and also the team that are supporting the Perioperative Care Transformation Programme at NHS England, because they're all working very hard in very hidden roles.
Yeah.
One last clarification for me, Ramani, the Sequin experiment with Dream, which is effectively, it's an incentive payment. Let's call it a form of bribery.
Yes,
it's carrot and stick, and it's the carrot piece.
But, the literature, when I've looked at it in the past, suggests the fact that education works pretty well, but then nothing beats bribery.
Yeah.
Did it work? I think you allude to the fact that it was working.
Yeah, it is working. It is working.
So the reward component of it, and it's a modest uplift, but it's very important things, does work as a way of getting change in practice and change in outcome.
We'll wait and see.
Okay.
Yeah.
Okay.
Good answer. Ramani, you are a doll. Thank you so much for sitting down with us and chatting and taking the time out of, I know you're very, very busy agenda. I think you're even headed on to other dinners and things outside of this. So
this was great. Thank you.
We appreciate it. Anytime you want to catch up, we would love it. Good luck to you. Can't wait to see the PQIP stuff come out soon.
Thanks, Desiree. Thanks, Monty. Thanks, everyone.
Cheers. And thanks for listening to Top Med Talk. We wanted to say a big shout out to our sponsors as well. We could not make Top Med Talk free and open access to the world without you. Thank you to GE Healthcare, Edwards Life Sciences, Medtronic. Thanks for helping making this happen. Cheers, everybody. Have a great day.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.